Hello everyone. Today's topic is cardiac stimulation. So as we know, cardiac current is a short frequency current and it is used to stimulate innervated muscles. We can use plain Faraday current. We can use interrupted Faraday current to stimulate innervated muscles. Right? Basically, Faraday stimulation stimulates the motor nerves if it is of sufficient intensity. It stimulates the muscle to which the nerve supplies. So basically it supplies to the innervated muscles. In case of neuropraxia, we use cardiac stimulation, right? So the contraction produced from this is a tetanic type of contractions because stimuli are repeated 50 times per second. It is an alternating current. It is a therapeutic current to treat the condition, right? So to avoid muscle fatigue, generally we use surge Faraday. Surge Faraday means there is an interruption between the impulses, right? So in this, we gradually increase the intensity and we gradually decrease the intensity. So which seems to be like voluntary contraction of muscle. So if the patient is unable to perform voluntary contraction, we use Faraday stimulation, right? So Faraday stimulation is used to facilitate muscle contraction, right? So when we apply Faraday stimulation, mild tickling type of sensation we feel, right? So first, always explain the procedure to the patient. In case of muscle re-education, we also use Faraday stimulation. In case of neuropraxia, a first degree of nerve injury, we use Faraday stimulation. To get pumping action, we use Faraday stimulation. So all these are the indications of Faraday stimulation, right? So today we will discuss procedure of treatment. So while giving treatment with neuromuscular electrical stimulation to the patient, it should be kept in mind that treatment must be effective, comfortable, and in a proper way. So the treatment should be done under the following procedures, right? First one is operator's preparation. Second is patient preparation. And third one is application of different techniques, right? Now we discuss operator's preparation. So for Faraday stimulation, Faraday stimulation is commonly used with automatic surgery. So before applying to the patient, therapist must consider the following points. Like first, we have to check the operators first. So testing of the operators. Attach the leads and electrodes to the terminals, holding the two current in moist hand and turning up the current until the mild tickling sensation is experienced and the muscle contraction is reduced, right? So first you have to check the intensity and response of the machine. Next point is describe the experience the patient will feel and make sure the patient can see the produced muscle contraction. Means you are going to explain the procedure to the patient. So duration and frequency of the surge should be set, right? So normal condition we use surge Faradic stimulation to avoid muscle fatigue, and this surge Faradic stimulation will be more comfortable to the patient. So duration and frequency of the surge should be set. The operator should be far enough from SWD to prevent output disturbance by the radio frequencies. Clear? So you have to keep the machine away from the SWD machine, right? Next point is the electrode should be dipped in tap water or in warm 1% saline to reduce resistance. Clear? Generally we use so many types of electrodes in Faradic stimulation. Like we use malleable metal tinplate or aluminum electrode. It is coupled to the skin with a water-soaked pad of lint, cotton, and gauze, or with some forms of sponge material. In this, we use malleable metal tinplate or aluminum electrode. Second type is carbon-filled silicon rubber electrode. It is coupled to the skin by thin layer of conducting gel and fixed with strap or adhesive tape. So generally in the lab we use carbon-filled rubber electrode with gel. One more type is water bath electrode, commercial pads, copper tipped electrodes, adhesive electrodes. So these are different types of electrodes we use during the treatment, right? Next thing is electrode placement procedure. We have to understand the electrode are placed over the nerve trunk and over the muscle belly for neuromuscular stimulation. So the following methods are used therapeutically. There are so many methods we can use. One is unilateral. Next one is bilateral. Next one is unipolar. And one more technique is that is bipolar. So now first we discuss unilateral placement. So in unilateral placement, it causes stimulation of one extremity or one half of a muscle pair. So this is called unilateral, right? When we stimulate one limb muscle or one half of a muscle pair, this is unilateral, means only one side. We are going to stimulate muscles. Second type procedure is bilateral. Bilateral placement causes stimulation of both extremities or both halves of a muscle, right? So this is bilateral procedure. Next one is unipolar. In unipolar placement, the stimulating electrode is placed on a target muscle with indifferent electrode elsewhere, and this electrode is usually termed motor point stimulator. So in this, we place active electrode on the motor point and the passive electrode or indifferent electrode over the nerve trunk. So this is unipolar method. Next one is bipolar method. So in bipolar placement, two electrodes are placed on the target muscle. One electrode we place on the origin point and the other electrode on the insertion point. Right? So this is bipolar method or bipolar electrode placement technique. So normally we use unipolar procedure, right? And we can also use bipolar method. So in unipolar method, we place active electrode on the motor point and the passive electrode on the nerve trunk, right? In bipolar, we use two electrodes. One electrode we place on the origin point of the muscle and one electrode on the insertion point to stimulate the whole muscle belly. Clear? So this is the electrode placement procedure, right? So in cardiac stimulation, we use two electrodes. One is active electrode and one is passive electrode. So as we know, cathode plays role of active electrode. It's a negative electrode and it is a stimulating electrode, right? Cathode. Another one is anode. Anode is a passive electrode, also known as positive electrode, and it is an indifferent electrode, right? Clear? So before applying the machine to the patient, we check the machine, leads and electrodes, right? Proper placement of electrode is very important to get good result, right? Next thing is patient preparation. So before giving treatment, it should be watched that the patient is warm so that the muscle responds to stimulation. Means patient should be in a comfortable position and the environment should also be comfortable. Next thing is The clothes from the area to be treated are removed, right? Next thing is properly support the area to be treated to relax or shorten the muscles of the part. So this position can be modified according to the effect required. For example, in re-education of muscle, clear? So when re-education of muscle action is to be done, arrange the patient in a position so that movement is reduced. When the muscle contracts, as in training the calf, ankle is kept in slight dorsiflexion. So plantar flexion can occur when the calf is stimulated. So positioning of the body part is also very important, right? When we are going to stimulate calf muscle, we place the ankle in slightly dorsiflexion position so that we can see the response of muscle contraction. Calf muscles are plantar flexors. So when we give badic stimulation to the calf muscle, it will contract and it will give plantar flexion response, right? So positioning of the ankle is important in this. And the skin should be washed with soap to remove natural oils. So by doing this, we can reduce impedance of the skin. Clear? Next thing is, before applying the pad, the skin is moist with saline water, which will reduce the skin resistance. As the skin has high resistance due to dryness and presence of few ions. So first, we have to reduce the skin resistance by moistening the skin. So for this, we can use normal tap water or we can use 1% saline water, right? And if the skin breaks, it is protected by little petroleum jelly, or we can use Vaseline covered with a small piece of non-absorbent cotton wool to protect the pad, right? So if the patient is having some skin abrasions, slight cut, so we can apply Vaseline jelly over the cut area. Then we can use electrodes. Clear? So indifferent pad should be large to reduce the current density, which is kept to minimum, and it prevents excessive skin stimulation and reduces the contraction of unwanted muscle. Here, so we place indifferent electrode on the nerve trunk and the active electrode over the motor point. Or we can place passive electrode on the origin point, or we can place active electrode on the insertion point of the muscle, which is going to be stimulated, right? So this is patient's preparation. So we have discussed operator's preparation and patient's preparation. Now we discuss different techniques of Faradic stimulation. So technique of treatment depends upon the effect we want. So either we want to stimulate the individual muscle or muscle group, So thus mainly 3 techniques are used. One is a stimulation of individual muscle. Second one is a stimulation of group of muscles. And third one is nerve conduction method. So we can stimulate individual muscle, or we can stimulate a group of muscles, right? So first we discuss a stimulation of individual muscle. Clear? So for this, we should know about anatomy of the particular muscle, origin point of the muscle, insertion point of the muscle, function of the muscle, and innervation of the muscle, right? So as each muscle performs its own muscle function, its own individual action, we can get the maximum contraction by stimulating the motor points. So motor point is a point on the neuromuscular junction where we get the maximum contraction with minimum intensity of the current. So first we have to find out the motor point, right? So this can be used to train a new muscle action or in isolation of one muscle. It is to be done. So motor point is usually found at upper and middle point of 1/3 of the fleshy belly of muscle. So motor points of extremities and face we should understand. Last class we had discussed facial muscles and upper limb muscles, right? And today we will discuss lower limb muscles, origin, insertion point, and action of muscles and innervation of muscles. Clear? So now we discuss lower limb muscles. In lower limbs, we have so many muscles like hip muscles, hip flexors, hip extensors, hip abductors, hip adductors, internal rotators, external rotators, right? Knee flexor, knee extensors, plantar flexors, dorsiflexors, interossei and lumbilicals. So first we discuss hip flexors. Anybody can name the hip flexors? Anyone in the class? Mansi, Jyoti, anyone? Name the hip flexor muscles. First, switch on your mic. Sachin. Hip flexor muscles. Name the muscles. Hip flexors.
Rectus femoris, iliacus, sartorius.
Yes. Iliacus, sartorius, and psoas major especially, right? So iliacus and psoas major are the prime movers. These are the main muscles. And the sartorius and TFL are the accessory muscles, right? So we know the function. Then origin of the psoas muscle is transverse processes of all the lumbar vertebrae from the ventral surfaces. So psoas major originates from transverse crosses of all the lumbar vertebrae and inserts as lesser trochanter, right? And this is supplied by the lumbar plexus, psoas major. Iliacus is also a hip flexor, originates from iliac fossa and inserts at lesser trochanter, right? And the iliacus is supplied by the femoral nerve, right? Next one is sartorius. Sartorius originates from ASIS, anterior superior iliac spine, inserts at medial surface of the shaft of tibia and supplied by the femoral nerve, right? It's a talar muscle, sartorius. And the action is flexion, abduction, and lateral rotation, right? Next one is hip extensors. Gluteus maximus and hamstrings. These are the muscles of hip extensors. Gluteus maximus is the prime mover, and the hamstring is a accessory muscle for hip extension, right? So origin of the gluteus maximus is posterior gluteal line from the gluteal surface and the lower part of the sacrum and the side of the coccyx, right? So it originates from sacrum, side of the coccyx, and from the posterior gluteal line, which is on the hip bone, right? And it inserts on gluteal tuberosity of femur and into the IT band, right? So this is gluteus maximus. It helps in hip extension. And this muscle is supplied by the inferior gluteal nerve, right? Now we discuss hip abductors. Hip abductors are, anyone? Hip abductors? Sachin, Akanksha, Sadhana, anyone? Hip abductors? Name the muscles. Hip
Gluteus medius.
abductors.
Gluteus
Adductor
medius.
magnus.
Pardon?
Sir, gluteus medius, gluteus minimus, abductors.
Yes. Gluteus medius, gluteus minimus, and TFL. Right? These are the hip abductors. So gluteus medius originates from between anterior and inferior gluteal line of lateral surface of ilium. Right? It inserts on the lateral surface of greater trochanter, right? And this gluteus medius is supplied by the superior gluteal nerve, right? And the action is abduction and medial rotation of hip, right? What is abduction? Hip abduction. When we move leg away from the midline, that is abduction, right? Abduction of hip. Clear? Next one is hip adductors. Hip adductors are, anyone? Hip adductors?
adductor longus, adductor brevis, adductor magnus.
Sir, Magnus
Yes,
longus
adductor group. Yes, adductor group. Adductor longus, adductor magnus, adductor brevis, pectineus, and gracilis. So all these are adductors, right?
medius.
So pectineus originates from superior ramus of pubis, inserts at pectineal line of femur from lesser trochanter to linea aspera, right? And the nerve supply is obturator nerve and femoral nerve, pectineus, right? Next one is gracilis, and this muscle is supplied by the obturator nerve. It is a adductor of hip joint. Then adductor longus. Adductor longus originates from body of the pubis and inserts at linea aspera on the middle 1/3 of the shaft of femur, right? Linea aspera is a marked line on the shaft of femur, right? So adductor longus inserts at the linea aspera. It is supplied by the obturator nerve. Next muscle is adductor magnus. Originates from ischial tuberosity, ischial ramus, and ischial ramus of pubis, right? And it inserts at linea aspera and adductor tubercle of medial condyle of femur, right? Adductor magnus. And it is supplied by obturator nerve and sciatic nerve, right? Next one is adductor brevis. It also helps in adduction, and it is supplied by the obturator nerve. So all these adductors, adductor longus, brevis, magnus, all these are supplied by the obturator nerve, right? Next one is medial rotators of hip joint. This includes TFL, tensor fasciae lata, anterior fibers of gluteus medius and minimus, semitendinosus and semimembranosus. But the prime mover is TFL, tensor fasciae lata. It is a main medial rotator of the hip joint, right? What is the function of TFL? Anyone? Function of TFL? Anyone? Function of TFL? Sumaya, Sadhna, Akanksha, anyone? What is the function of TFL?
Sir, rotation of the leg at the hip joint.
Rotation of the leg. Medial rotation or lateral rotation?
Medial rotation.
Yes, it helps in medial rotation, TFL, right? So basically flexion, medial rotation, and abduction of the hip joint is done by this TFL, right? So TFL helps in flexion of the hip joint. It helps in abduction. It also helps in medial rotation of the hip joint, right? And this muscle is supplied by the superior gluteal nerve, right? Superior gluteal nerve. Next muscle is gluteus minimus. It is also an abductor of hip joint, gluteus minimus, and it is also supplied by the Same nerve, superior gluteal nerve, right? Next one is lateral rotator of the hip joint. So piriformis, gamelli, obturator externus, obturator internus, all these are the lateral rotators of hip joint, right? Like piriformis originates from pelvic surface of middle three pieces of sacrum, means it originates from sacrum piriformis and inserts at the apex of greater trochanter of femur, right? Piriformis originates from sacrum and inserts at the greater trochanter of femur, right? Next one is gamellar superior. It is also supplied by nerve to obturator internus. Next muscle is gemellus inferior. Originates from ischial tubulosity and inserts at greater trochanter. And the nerve supply is nerve to quadratus femoris, right? Next one is obturator internus and obturator externus. Both are lateral rotator of the hip joint and supplied by the obturator nerve, right? So origin and insertion point of the muscle is very important before giving muscle stimulation. So you have to understand, you have to learn the origin point of the muscle, insertion point of the muscle, right? And innervation of the muscle. Clear? Now we discuss hamstring muscles. Hamstring muscles are the knee flexors. There are three components: biceps femoris. This one is lateral hamstring. And the semitendinosus and semimemnosus are the medial hamstrings, right? So hamstrings are the muscles of posterior part of the thigh. It helps in knee flexion, right? So on the medial side, you will get semitendinosus and semimembranosus. On the lateral side, you will get biceps femoris, right? So semitendinosus originates from ischial tubulosity and inserts at the upper part of medial surface of the shaft of tibia, right? On the medial side. And this one is supplied by the sciatic nerve, right? Semitendinosus. Then semimembranosus. It is also supplied by sciatic nerve. And it helps in flexion and medial rotation of knee. It also originates from ischial tubulosity and inserts at the medial condyle of the tibia in the groove, right? Now we discuss biceps femoris. It's a component of hamstring on the lateral side. In this we have long head and short head. Long head originates from inferior-medial impression on the upper part of ischial tubulosity, right? And the short head originates from lateral lip of linea aspera. And it inserts on the head of fibula, right? Biceps femoris. It inserts at the head of fibula, right? So it helps in flexion and lateral rotation of the knee. Clear? So semitendinosus, semimembranosus, and biceps femoris. These are the components of hamstring muscles. So hamstring muscle, knee flexors, right? So semitendinosus, semimembranosus, both originates from ischial tuberosity and inserts on the medial condyle of the tibia, right, on the upper part, and the biceps femoris, it inserts at the head of fibula, right? Now we discuss quadriceps femoris. It is the muscle of anterior part of the thigh, quadriceps femoris. It has 4 components. One is rectus femoris, vastus lateralis, vastus medialis, and vastus intermedialis. Right? Means it's a combination of 3 vasti and 1 recti, rectus femoris. Right? And this muscle is supplied by the femoral nerve. Clear? And the action of quadriceps is extension of the knee joint. Clear? Now we discuss gastrocnemius and soleus. These are plantar flexors. This gastrocnemius originates from medial condyle of femur, and the lateral head of the gastrocnemius originates from lateral condyle of femur. So medial head of gastrocnemius originates from medial condyle of femur, and the lateral head of gastrocnemius originates from lateral condyle of femur. Right? And it inserts at calcaneum, that is tendocalcaneum. Right? It forms a tendon, tendoachilles, calf muscle. And this muscle is supplied by the tibial nerve. Right? Tibial nerve. So gastrocnemius and soleus both are supplied by the tibial nerve. Right? Soleus originates from the soleal line and the medial border of shaft of tibia on middle 1/3. Right? So there is a soleal line on the tibia. So from there, soleus originates and inserts at posterior surface of calcaneum with a tendon of gastrocnemius as tendocalcaneus. Right? Supplied by the tibial nerve. And the function of gastrocnemius soleus is plantar flexion of ankle joint. Right? Next one is tibialis anterior. Tibialis anterior originates from tibia, the lateral condyle. Also originates from shaft of tibia and the adjacent interosseous membrane. And it inserts on the plantar aspect of medial cuneiform bone on the medial side. Right? This tibialis anterior inserts at the cuneiform bone, medial side. Right? So what is the action of this muscle, tibialis anterior? That is dorsiflexion with inversion. Right? Dorsiflexion with inversion. tibialis anterior. When we resist the movement, we can palpate the tendon of tibialis anterior, right? So when we resist this movement, dorsiflexion inversion, then we will get a prominent tendon, that is tibialis anterior, right? The next muscle is tibialis posterior, originates from posterior surface of shaft of tibia on upper and lateral part of soleal line and the posterior surface of fibula, right? And it inserts on tuberosity on the navicular bone. So tibialis posterior inserts at the navicular bone and supplied by the tibial nerve. Tibialis posterior. What is the function of tibialis posterior? Anyone? Function of tibialis posterior?
Inversion.
Pardon?
The foot
Plantar
inversion.
flexion. Plantar flexion. Plantar flexion.
Right. Plantar flexion with inversion. Right. Plantar flexion with inversion. Right. So this is the function of tibialis posterior. Clear? Next is peroneus longus, peroneus brevis, and peroneus tertius. It helps in eversion of the foot. Right? So first we discuss peroneus longus. Originates from the lateral surface of the fibula. Right? And the lateral condyle of tibia. It inserts at base of first metatarsal and medial cuneiform bone on the lateral side, and it helps in foot eversion, right? And the peroneus brevis, action is same, eversion of the foot and supplied by the superior peroneal nerve, right? So eversion of foot and plantar flexion of ankle joint, right? This is the main function of peroneus brevis and longus. And both are supplied by the superficial peroneal nerve. And the role of peroneus tertius is eversion with dorsiflexion. Peroneus tertius, eversion with dorsiflexion, right? And this muscle is supplied by the deep peroneal nerve. Clear? Next important muscle is extensor hallucis longus. It helps in extension of great toe, supplied by the deep peroneal nerve. Extensor hallucis brevis, supplied by deep peroneal nerve. And the action is extension of MTP joint of great toe. So these are the important muscles of lower limb, right? Origin, insertion point, and function of the muscles, right? So to initiate muscle contraction, muscle re-education, relearning muscle action, maintenance or increase in range of movement of the joint, venous and lymphatic drainage improvement, in case of neuropraxia. In all these conditions, we use Faraday stimulation, right? So we can stimulate the muscle individually, or we can stimulate the muscle in a group, right? So in last class, we had discussed quadriceps rehabilitation and foot bath under water with Faradayism, right? So first we discuss stimulation of individual muscle. So as each muscle performs its own individual action, we can get the maximum contraction by stimulating the motor points of the muscle. So this can be used to train a new muscle action, or in isolation of one muscle, it is to be done, right? So to get maximum contraction, we should stimulate the motor points of the muscle, right? So to stimulate motor point of a muscle, anode is applied and secured in a suitable area, mainly over nerve trunk of muscle to be stimulated, right? Because the anode is a passive electrode, we place the passive electrode on the nerve trunk, right? So the active electrode is held between the index finger and the thumb. It is placed over the motor point of the muscle to be stimulated. So we place passive electrode on the nerve trunk and the active electrode on the motor point. So a suitable duration and frequency of surge must be selected, right? Surge means interruption between the impulses. So normally we use surge Faraday, right? So after applying the electrode, intensity of current is increased gradually until a good muscle contraction is obtained at the maximum point of each surge, right? So in case of re-education of muscle, patient is told to do voluntary muscle contraction with electrical stimulation at the same time, right? So the current may needs to be increased and decreased as the exact motor point is found. Means first you have to find out the motor point, right? And a good contraction can be obtained with less current, right? The next point is to enable the patient to cooperate the length of the contraction. The intervals between them should be suitably long. So this allows the patient to match the effect with the suitable contraction and an adequate rest between each one. Means there should be a gap, or there should be an interruption, or there should be a surge between the two impulses, right? So that will give a better result. Clear? Next thing is stimulation of group of muscles. Now we are going to stimulate a group of muscle at the same time. So when a muscle group is to be stimulated, the active pad can be made to cover all the motor points, or the two pads may be of approximately the same size, placed at the either end of the muscle group so that the current is spreads through the whole group, right? So one electrode we have to place on the origin point, and the other electrode we can place on the insertion point to stimulate the whole muscle. So stimulation of muscle group is mainly done in muscles of pelvic floor, in quadriceps rehabilitation, and the small muscles of foot. Right? So what are the muscles of pelvic floor? Pelvic floor muscles, we have heard pelvic floor muscles, you know. So pelvic floor muscle are like levator ani, coccygeus, pubococcygeus, and ischiocavernosus muscles. These are the pelvic floor muscles, right? So electrical stimulation of pelvic floor muscle is mainly used in prolapse of pelvic organs and stress incontinence, right? In both the conditions, we have to stimulate pelvic floor muscles. Clear? So for re-education of pelvic floor muscles, it requires a special technique to stimulate sphincter muscles of urethra, right? So in case of stress incontinence, we stimulate pelvic floor muscles. What is this incontinence? When the patient is unable to hold urine. So this condition is known as incontinence, right? So for strengthening the muscles, pelvic floor muscles, we use Faraday stimulation, right? So for this, we prepare the patient, we prepare the operators, we position the patient in side lying position or crook lying position with a pillow between the lower legs. We place a plastic sheet under the patient and we place indifferent electrode on the lumbosacral region. That is a passive electrode, right? So we place passive electrode on the lumbosacral region and the active electrode is placed in vagina or rectum after applying the sterilized lubricant jelly over the electrode, right? So one passive electrode we place on the lumbosacral junction and one electrode in the anus or vagina, right? So active electrode is placed in vagina or rectum after applying the sterilized lubricant jelly. So in males, we place active electrode in the rectum. In females, we use vaginal electrode, right? So we select a suitable duration and frequency. We increase the intensity gradually until strong contraction is achieved, right? So voluntary contraction must be attempted at the same time while giving periodic stimulation, right? So we motivate the patient to contract the pelvic floor muscles along with the electrical stimulation, right? So this is pelvic floor muscles rehabilitation. For quadriceps, we place passive electrode on the femoral trunk or femoral triangle. There is femoral nerve. We are going to stimulate femoral nerve. So we place passive electrode on the femoral nerve and the femoral triangle and the active electrode on the motor point, right? Then we select a suitable duration and frequency. Gradually, we increase the intensity until a strong contraction is achieved. And the patient is motivated to do voluntary movement during the treatment session. Right? So this is quadriceps rehabilitation. Especially in sports person, we need this quadriceps rehabilitation. Next one is Phyadism underwater, also known as phyadic foot bath. It is mainly used for the foot muscles. When a muscle group is to be stimulated, the active pad can be made to cover all the motor points, or the two pads may be of approximately the same size, placed at the either end of the muscle group. Right? And this causes current to spread through the whole group. So this is phyadic foot bath. We have discussed earlier. So in this, then we have to stimulate interossei. We place indifferent electrode or passive electrode on the under the heel, right, and the active electrode under the MTP joints, right, to stimulate interossei. When we want to stimulate lumbricals, we place electrodes either side of the foot, right? So the method is used for reduction of limb edema, phyadism under pressure, and muscle group of the limbs can be stimulated rhythmically to effect a muscle pumping action, enhancing the lymphatic and venous flow to assist reduction of edema. Right? So this is all about phyadic stimulation. As we know, phyadic stimulation or phyadic current is of short duration, ranging from 0.01 millisecond to 1 millisecond. And it has a high frequency ranging from 50 to 100 hertz. Right? And it is used to stimulate innervated muscles. Right? And it gives a mild tickling type of sensation. Here. So when any nerve is damaged severely, there occurs degeneration. Right? So after degeneration, muscle can be stimulated by interrupted DC. But degeneration takes long time. So in early stage after the injury, muscle can be stimulated by the phyadic type current. Right? So in early stage, we use phyadic stimulation. And when the degeneration occurs, we can use galvanic current. Right? So this is all about phyadic stimulation. So if you want to ask anything, you can ask. In next class, we will discuss galvanic current. In this chapter, we had discussed characteristics of phyadic current, types of phyadic current, physiological effects of phyadic stimulation, indications and contraindications of phyadic current, and the application of phyadic stimulation. We can stimulate individual muscle, or we can stimulate a group of muscles, right? Pelvic floor rehabilitation, quadriceps rehabilitation, and Friday foot bath, right? So anyone, if you want to ask anything, you can. So revise the chapter, right? In next class, you can ask.